Next, we would like to invite Mr. Dr. Shamsuddeen as a presenter of public health with the topic Knowledge of Community-Based Health Insurance Among Residents of Kurdistan State, Nigeria, a comprehensive cross-sectional study. Hi, Dr. Shamsuddeen. Stage is yours. You can start your presentation by sharing your screen.
Thank you. Yeah, good afternoon, good day, everybody. My name is Dr. Shamsuddeen Suleiman. I'm going to make presentation on the knowledge of community-based health insurance among residents of Katsina State, Nigeria, a comparative cross-sectional study. By way of introduction, community-based health insurance is a form of micro-health insurance, which is predominantly termed for health insurance targeted at low-income earners. One of the unique features of community-based health insurance is the community involvement in taking the lead in its setup and its management. This community-based health insurance is generally designed with the following features: pooling of health risks and with voluntary payment. And enrollment into any form of insurance is very low in Katsina State, northwestern Nigeria, with majority of people paying out of pocket to access healthcare. Knowledge of community health insurance has been found to influence enrollment into community health insurance, which helps to avoid catastrophic healthcare expenditure. The research question is, what is the difference in knowledge of community-based health insurance between community-based health insurance member households, that is those that have enrolled into the scheme, and non-member households? And the hypothesis is there is no significant difference in knowledge of community-based health insurance between community-based health insurance member household and non-member household. And the objective of this study is to compare the difference in knowledge of community-based health insurance between member households that have enrolled and those that have not enrolled into the scheme, and to determine the factors associated with the knowledge of community-based health insurance. Household heads that are 18 years old and above who engage in informal sector for source of living are included in these studies, and also enroll into the community-based health insurance and are benefiting for more than 1 year, and we are not covered by other social health insurance schemes. So this is the inclusion criteria for this study. And household heads that were employed in the formal sector for source of living, including pension and or covered by other insurance schemes, were excluded from this study, because as I've said earlier on, this study is mainly for those in the informal sector. That is why this set of people are excluded. And the sample size was estimated using the studies designed for comparison of two groups: population proportions formula with the following assumption: 80% statistical power with a level of significance set at 5%, insured to uninsured ratio of 1:1. And the proportion of health service utilization was 35% for the insured household and 20% for the uninsured household. And this is the formula you can see. And where P1 is the proportion of health service utilization was set at 35%. And the P2, you can see the values. And we have the, as I've said, a total sample of 134 was gotten. And the allowance for 90% response rate, the minimum sample size was given as 149, which is approximated to 150 per group. So you have 150 people who are insured and 150 people who are non-insured. This is a cross-sectional comparative study design, and I'm using the sampling, multi-stage sampling technique is the sampling technique which I'm using. Usually, the Mutual Health Association constitutes about 12 community units. They have a total registration of about 41,219 members. So because it's a multi-stage sampling, the first stage is involves selection of one community from each senatorial zone using simple random sampling. In Katsina State, we have 3 senatorial zones. So we are going to, first stage is to pick one community per senatorial zone. Then in the second stage, you use selection of the community, which is the first stage, and the second stage is the selection of the systematic sampling was used to select the study subject, which we picked from the 3 communities as at the first stage. Then second stage is the systematic sampling was used to select the study subjects, while in the last stage, you select actually the respondents. So the data tools we use are survey questionnaires, which we are converted into ODK. They are preloaded on Android phone by the enumerators. And measurement of the variable, we use a score of 50% and above is regarded as the adequate knowledge, while score less than 50% is regarded as inadequate knowledge. The study variables, the dependent variable of the study is the knowledge of community-based health insurance, while the independent variables were the community-based health insurance scheme membership status of the household, their demographic and economic characteristics of the individual health of the household, such as the age, sex, marital status, education, and occupation of the household. So this is the what is regarded. And data was analyzed using SPSS version 25. And before data was collected, the survey instrument was pre-tested in a different local government area, and about 10% of the sample size was used for the pre-testing. And ethical approval was sought and obtained from Katsina State Health Research and Ethics Committee, and before the commencement of the study. So this is the result. Table 1 is socio-demographic characteristics of the respondents. You can see the total sample is 150 per group. That's those that are enrolled membership and non-members. But you can see that the majority of the member groups are within the age range 41 to 60 years, while for the non-member group is the 20 to 40 years age group. Then almost all the respondents are male in that's 97.3% of the member group, while the non-member are also male, are also majority with 82.7%. And most of them, majority of them for the are married, 84.7% for the membership group, while 99.3%, almost all of them are married for the non-member group. So, and in terms of the ethnicity, almost all 95.3% versus 92% were married for the two groups. In terms of level of education, the highest proportion, almost nearly half of the study participants in the membership group had only Quranic education, while 31.3% have primary education. For the other group also is a similar picture with 52.7% of the non-member group also had only Quranic education, and about 24% had primary education. In terms of the occupation, most of them in the membership group, 47.3%, nearly half are business. They are involved in petty business, while followed by farming. For the non-member group, 46.7 also are into business, then 42% are into farming. So this is the figure 1 sex distribution of the respondents. We can see males are male are the predominant respondents. The community-based health insurance is modeled as a household at the household level. So in Katsina State, northwestern Nigeria, most of the communities headed by households are headed by males. So you can see males for both the groups enrolled and the non-enrolled. You can see males are the predominant group. Then this is the indices that was used to assess the knowledge of community-based health insurance, whether health contribution helps reduce out-of-pocket spending, in terms of formation of the mutual health association, and other questions where you see the difference between those that were insured or enrolled members and non-members. This table 3 is the respondents' awareness and source of information on community-based health insurance. Almost 99.3% of those that have been enrolled have heard of information about community-based health insurance, while almost 3/4, 76% of those that are not enrolled also have heard about the community-based health insurance. And the predominant source of information on community-based health insurance is from the community leaders, followed by friends and colleagues, and then the healthcare workers. For the non-insured group also, community leaders are the predominant source of community-based health insurance, followed by friends and colleagues, while the radio structure television is the least source of information. And this is the aggregate knowledge on community-based health insurance between members and non-members. You can see for the community-based health insurance member group, 56.7% have adequate or good knowledge of community-based health insurance, compared to 43.3% of the non-member group. And the difference is not statistically significant. P-value is at 0.07. Then this is trying to look at the relationship between the socio-demographic variables and the knowledge of community-based health insurance. You can see that age of the respondents, that is the caregivers, the households, you can see p-value at 0.02, as well as number of children in the household. They are the two factors that are found to be associated with the knowledge of community-based health insurance, while other socio-demographic variables like level of education, the occupation, and the marital status, have not any significance in that. In terms of the adequate knowledge is associated with uptake and willingness to enroll into the community-based health insurance, and knowledge and understandings have been identified as enablers to effective community-based schemes. A study conducted in Nigerian capital city realized that only 13% have good understanding on the concept of the scheme. This is in contrast from this study, whereby both member and non-member groups have awareness of about 99.3 and 76.7% respectively. If you look at the two communities, Nigeria capital city is an urban area, while for the this study setting, Katsina State largely is a rural setting, and this study was done in a rural setting whereby there are a lot of community cohesion. People live together in close harmony, And because of this scheme has been long-standing, so there is a lot of information sharing among member groups. And in conclusion, knowledge of community health insurance is higher in insured group than non-insured group, but there is still a knowledge gap in both groups to ensure that healthcare is accessible to all. Community health insurance should be promoted and more people should be encouraged to join so as to address the catastrophic healthcare expenditure, and people should be able to have financial access to healthcare delivery. These are some of the references which I have used, and thank you for listening.
Thank you, Dr. Shamsuddeen. Dear participants, if you have any questions, please raise the questions in the chat box so that Dr. Shamsuddeen will explain it. And Dr. Shamsuddeen, please update your email ID over there so that if any participants need any queries or clarification, they can write to directly. And also for Dr. Shamsuddeen, we open the poll session for the topic presented by him under the public health stream, knowledge of community-based health insurance among residents of Katsina State, Nigeria, a comparative cross-sectional study. Okay, you have a question, Dr. Shamsuddeen. Please, can you enlighten me again on your technique for sample size calculation in the chat box?
Okay, thank you very much. In the sampling technique, I used a multi-stage sampling method. You can see we have a distribution of communities. Like I've said, Katsina State is divided into 3 senatorial zones. We have the north, the central, and the southern sampling. So this is the total number of people that have been mutual associations, where these are the places where you have community-based health insurance operating. And so the stage 1 is the selection of community from each senatorial zone. And from for Katsina zone, we have Dusama was randomly selected from the list of mutual health association with 2,995 members, while the Daura zone, Upik Mashi was selected with 3,390 members, while the Funtua zone, Dabai was selected with the 5,727 members. So proportionate allocation was used to select the study respondents, and we look at the registered financial members, which have shown about 42,000 over the total registered financial members. Based on that, for the 3 zones, we allocated proportionately 37, 42, and 71. So this gives the number of study respondents to be interviewed from each community. While for stage 2 is a systematic samplage, which was used to study, the financial members. You have the sample interval, which is, you have your sampling frame divided by the sample size, which will give you 81. So using the simple random sampling, a number was selected between 1 and 81 by bulletin, which was started, and that is how we were able to select all the study subjects. I hope I've made it clear.
So, Doctor, you have another question. Was there a relationship between time into the scheme and knowledge about CBHI?
Yes, I have not. I have not reflected that, but yes, further analysis, there is a relationship between members that have been enrolled into the scheme longer tend to have more knowledge than members that have not enrolled into it.
Okay, you have another question, Doctor. Were you surprised that knowledge of insurance is higher among insured households?
No, it's not. You know, these communities, they live together. And if you look at the source of knowledge, it's predominantly from the same, community leaders. And because it's a close-knitted society, even though some people have not, are not enrolled, but because I'm trying to explain why, yes, both groups have, the insured have more knowledge because they have participated. There are some nitty-gritty questions they understand about the scheme more than what the non-insured group have seen. And other studies have shown that people that are enrolled, of course, you expect them to be more knowledgeable, but the level of knowledge is not much, looking at the fact that the predominant source of information is from community members and from family and friends. Yeah, in a family, you can have people who who have enrolled, and some have not enrolled, but there is free flow of information among the family members.
Okay, there is a question in the chat box. Do you think the contrasting results between your work and the previous work could be due to sanitization activities of your community as time went on?
Yes, likely, you know, like I've said in my study setting, mostly they are in community settings. As you know, in the community settings, people live closely together. And because the program has been long-standing, a lot of information sensitization has been going on. And the contrast we have with the other study was largely on urban setting, whereby community sensitization is not very prominent in that setting. So this could have attributed to the difference in terms of the findings that we have got.
Okay, doctor, you have two more questions here. Is there any plan to do comparison with the NHIS and the community insurance in the areas?
Yes, this is one of the things we need to do. We have the NHIS, the National Health Insurance Scheme, and we have the state-based contributory health scheme, which is done by the scheme. We plan to do also to compare other variables in terms of the knowledge, in terms of utilization, in terms of satisfaction with the utilization of these services. These are some of the things we plan to do.
Okay, the last question. Do you think there are other cultural factors that may explain the contrasting results?
Yes, like I've said, if you look at the socio-demographic characteristic of those two communities, both the enrolled and not enrolled, even though they are quite similar in terms of the age, in terms of even the occupation and others, there could be, we are further exploring to see what really made those people who have enrolled to be different from those who have not enrolled. But basically, those communities are quite, it's a homogeneous comparison looking at the socio-demographic characteristics of both the enrolled and the not enrolled. But one thing is sure that in terms of source of information, you know, radio and other the media, you know, is quite low in terms of the information. So they need to ensure that we advocate for the radio and the television and even the print media to make sure that programs are targeted to encourage people to enroll into these schemes and to have correct knowledge so as to ensure that catastrophic healthcare expenditure is reduced to the barest minimum and better uptake.
Thank you, Dr. Shamsuddeen. It's a nice presentation, and as well as you answered all the questions. And the final questions reached in the chat box that what is the rate of acceptance and enrollment of CBHI amongst the poor and vulnerable?
Yeah, unfortunately, the rate of acceptance is not much. Looking at, we've done a baseline survey, looking at the number of people, percentage of people that pay out of pocket. So it's almost 97% of people in the state, predominant means of accessing healthcare, mode of healthcare finances through the out-of-pocket, which could lead to catastrophic healthcare expenditure. But recently, there is effort to ensure that most of these schemes, people are enlightened to join. And the fact that community-based health insurance is voluntary, and people, the defaulter rate is very high. People will start paying, but because it is a voluntary scheme, people default. But concerted effort is being made by the government and to ensure that other forms of the community-based health insurance are implemented so as to reduce the level of expenditure through the out-of-pocket spending.
Dear participant, if you have any questions, please post in the chat box. Thank you, Doctor, for sharing your email ID. So, dear participants, if you have any questions or related to any queries of the topic submitted by Dr. Shamsuddeen, knowledge of community-based health insurance among residents of Katsina State, Nigeria, a comparative cross-sectional study. If you have any queries related to this, please contact him personally and get the clarifications over there. Thank you for your wonderful presentation.